Hi, this is Kim Roth coming to you with my nutrition case study for course APN 785. So this is the setting for this case was Tulip Special Care, which is a 60-bed skilled nursing facility in Philadelphia. It specializes in caring for adults that are hooked up to ventilators or who have severe respiratory needs. It employs one registered dietitian and me, the intern. And the patient is MW. He's a 52-year-old African-American male, a height of 5'11". He weighs 104 pounds with a BMI of 14.5, which puts him in the underweight category. He has a usual body weight of 190 and an ideal body weight at 160. So those discrepancies in weight make sense in the context of ALS. He is an ALS patient, kind of at end stages of ALS. So this is a list of his admitting diagnoses. The blue ones are the acute events that brought him into the hospital, and then we got him from the hospital once he began to stabilize. And he still is dealing with the effects of those blue diagnoses, and then also his all these other white ones that are related to his ALS. So what is ALS? I liked this infographic from the ALS Association of Texas. ALS stands for amyotrophic lateral sclerosis, which is, as the graphic says, a progressive neurodegenerative disease, and it is 100% fatal. Folks who get ALS end up dying from complications from the ALS. And I liked that this graphic broke it down to just even using the words themselves. Eventually, your nerves harden and stop sending signals through your muscles atrophy, and you end up with all these complications. The complications you can see are on the left here. So because he has ALS, he is a functional quadriplegic. He wasn't in a wheelchair for most of his adult life, but once he started losing his nerves in his legs and his muscle in his legs, he is now in a wheelchair. He does still have minimal use of his hands. He has no fine motor, but he can kind of move around, and he has a computer system that is set up for him with very large buttons to tap certain things that he needs on a regular basis. So his lung function is poor now. It is worsening. He does have COPD and emphysema now that he is also losing some lung function. He's anemic. Whether related to the fact that his GI system is no longer absorbing his nutrients properly. It's probably exacerbated by the acute events he was brought into the hospital for. And he's ventilator dependent because of the combination of the acute events in the setting of his chronic breathing events due to the ALS. So these were those acute events, which also make sense in the context of ALS. So he got pneumonia, he aspirated while eating or drinking, and then that infection led to a collapsed lung, which is the pneumothorax, and respiratory failure, which is why he's on a ventilator. His admitting lab values. So he had some wonky lab values, but they all do make sense based on his whole situation. So his glucose was high, but he had just been in the hospital with the infection. That kind of makes sense. His CO2 was high. The CO2 was high because of his respiratory issues. That makes sense. His creatinine was low. His creatinine was low prior to admission because of the muscle breakdown. The rest of his renal labs were fine. So the low creatinine is pretty standard for ALS patients because of their muscle breakdown. His red blood count and the hemoglobin were low, again, respiratory issues and his anemia. The medications they had him on. So the first one is just pain medication due to the pain of the collapsed lung. Next he's on, that's just an anticoagulant. They want to prevent against blood clots in his lungs and further, issues with that. Sodium chloride he was on when he got there. His electrolytes had been wonky in the hospital, and so he was on that. Albuterol just for his respiratory needs, and that's kind of as needed with progressing him from 100% ventilation to kind of like trach collar and things like that. And then he was on a pretty big vitamin regimen, which is recommended for ALS patients. Anyway, he regularly takes a multivitamin every day. He takes, all the list of what's there to combat different common deficiencies for patients with ALS. So that's pretty standard care. And he was really good at taking them regularly. Social history, music production. So he used to work in music production. He is single, he has a daughter, he lives with his mom who helps with his care. He has a home health aide that comes out 2 to 3 times a week. He has a pretty big support network, friends, extended family, brothers and sisters, things like that, who are all really involved in his care. He takes really good care of himself, and he is knowledgeable about what is commonly recommended for ALS patients and how to kind of do the best that he can in his situation. And with that comes his lifestyle history. So he does have a past history of using different substances. He was a smoker. He used alcohol, drugs, things like that, which all stopped once he was diagnosed with ALS. And he started taking his care seriously. Nutritionally focused physical exam findings. So he came to us with severe weight loss, which again is common end-stage ALS. Severe loss of subcutaneous fat, severe loss of muscle mass, noted fluid accumulation, edema in his legs, things like that, and reduced grip strength. Reduced grip strength, most likely more to do with having ALS than malnutrition, but they kind of go together. So his main problem from a nutritional standpoint is malnutrition. So our PES statement that we came up with was severe malnutrition in the setting of chronic disease related to advanced ALS and recent hospitalizations, as evidenced by a BMI of 14.5, significant reported weight loss of 39 pounds in 6 months, which is a 27% loss, noted edema, and severe loss of subcutaneous fat and muscle mass. So what did we want to do for his nutrition care process? Initially, we put him on night EN tube feedings. He actually came to us on these night feedings from the hospital. He's on, we switched his formula to Gevity 1.5, 70 milliliters an hour for 12 hours, so just at night, which is a total volume of 840 milliliters and 1260 in terms of kcals. Protein at 54 grams as from this formula feeding at night. We switched this formula because we didn't carry the one he came on. I can't remember which one it is, but it was a pretty comparable brand, so that was fine. During the day, he was on a mechanically soft diet as he was able, and it started pretty low. He was pretty tired when he came to us. He's still recovering, the transfer, all those things. The first day, I think he only drank Ensure. I don't actually think he ate anything, but he did progress steadily, and that was actually his stated goal was he did not want his tube feeds to last all day. He only wanted them at night because he wants to be able to eat during the day. He still does enjoy eating when he's able, and he wants to keep that as part of his life for as long as possible. So anyway, so that was kind of, he came to us low, and so we started with him with Ensure just to kind of like give him all of the micronutrients that we could possibly do. And it did progress, which was great. We put him on, with this night tube feeding, he was on a freshwater flush too, which is right there. His goal was to increase his PO intake as able. And for ALS patients, the goal intake is somewhere around 45 kcals per kilogram. And it does, as based on like tolerance, and there's a lot of other things that you have to look at too. But that is kind of what they're recommended to be at. So that was kind of we started him on this with that goal in mind. At the beginning, he probably wasn't getting that amount, but he was still recovering, and you kind of had to go little baby steps forward. Oh, and the monitoring and evaluation for that, really we were going to monitor his PO intake, and then the plan was to adjust his tube feeding regularly. So if he was like getting to a place where he was able to have a pretty large PO intake, we could back off on the tube feeding a little bit. We're monitoring his weights. We would like him to gain weight. We were monitoring his labs. Is he getting better? Is he getting worse? Is he, we're watching out for dehydration. We're watching out for some things. Monitoring his tube feeding tolerance. He was pretty good about telling us if he wasn't feeling well, if he was nauseous, vomiting, things like that, which he wasn't actually vomiting at all in the hospital. But there were, especially at the beginning, there was a couple of days where he was kind of like, I'll just take the Ensure. I don't want anything else. And then, as I said before, we're evaluating this data and then making changes accordingly. So after 4 weeks, he progressed, significantly, actually. We cut back his nighttime tube feedings a little bit. So then we cut him back to 65 milliliters an hour. which ended up being 1170 kcals, and he was getting 50 grams of protein in that tube feeding, which worked out to like a 1.1 gram per kilogram ratio. And because he was getting, so he was getting a freshwater flush too, but because he was getting food during the day, and we were doing a calorie count on him too. He was getting around 1,000 kcals PO during the day after 4 weeks, which was great, which is why we cut him back to 65 milliliters an hour. And so the days where he wasn't eating as much protein, we would just get him. He liked those gelatine, which is like a high protein Jello product. It has like 20 grams of protein per Jello. He liked those. So the days where we felt like he wasn't eating enough protein, we just, hey, you want one of these? And he would eat it, and great. Worked out to about 2170 kcals per day, which is right on that 45 kcals per kilogram. And that's like an approximation because, we weren't like weighing his food. So that was just based on like a rough calorie count of what he was getting PO, plus what we know he's getting through his tube feedings. And then his lab values looked great too after those 4 weeks, which is great. So his glucose normalized, his CO2 normalized, his red blood count and his hemoglobin also normalized. His creatinine was still low, but again, he does have ALS, and so that's typical. And his creatinine was still low, but it was raising itself slowly. It was improving. And by the end of the 4 weeks, we could scratch off the diagnosis of anemia at that point, which was great. And he was still ventilator dependent, but he only was sleeping attached to the vent. And then he was just trach collar during the day. He was improving. He was recovering as much as is possible given his ALS from his acute events. And again, his new nutrition-focused physical exam findings. So he still has severe weight loss, but he had put on 2 pounds in the 4-week period of time. Actually, I'm sorry. He had put on 2 pounds from like a 2 or 2.5 week period of time, I guess. By the time we got a legit weight on him, that's how much time had gone by. Anyway, he still had, he still has his fat and muscle losses, but he did have notably less edema in the nursing notes. So that was great. And he's going to have reduced grip strength because he's just going to have reduced grip strength. So then we started talking about discharge planning, which was really exciting because he really did want to go home, which was a big interdisciplinary team event. So everyone shuffled in the office from, the OT team, the respiratory care team, nursing, dietary, things like that. And so we were looking at, okay, how is he doing? What notes do we need to make sure his specialty team has? What equipment does he need at home? Things like that. And we were able to get in contact with his specialty team that he sees at like a nearby ALS specific clinic. And we gave them all the information that we could so that they could then pick up care as needed once he was discharged. And really with somebody like him, you're looking at a combination of like palliative care and recovery care. So we know he is recovering from kind of like these acute events that he had experienced, but he's also in palliative care at this point. He is, end stages ALS. Prognosis isn't long for him, but how can we support him in having the greatest quality of life for the longest amount of time? So, it was a funny combination of goals. And ultimately, he was discharged home, which is great, especially coming from this long-term care setting where not many people are discharged home. This was kind of like a nice, tidy little case study where, patient came in with issues. We did what we could nutritionally. He made progress enough to be able, in all areas, enough to be able to go home. So that's great. So it's, we're thankful that he can be home with his family longer. And that is my case study. So thank you so much for watching. Goodbye.